in the last, let's say, 100 years, the way we practice medicine has changed because everything is being measured in a quantifiable manner. There is more digitalization, and everything has been centered around this concept of biomarkers, and that's changed the way we interact with patients and the way we practice medicine. And then now we are going into the age of digital biomarkers, where we're either putting an AI on top, and we're also measuring things in all kinds of ways, from our smartwatches, from our sensors, from cameras, everything. And that, I feel, is the way we're headed, and will change the course of how we practice medicine in the future. So this is how we test for coordination. Touch my finger, you touch your nose, touch my finger again, back and forth as best as you can. And we subjectively gauge, how good they are at localizing to the finger.
What? How is that possible? I don't get this. I feel like we are doing like kindergarten science.
Where all of this is going is, if you have better biomarkers, especially for these diseases which are hard to quantify, and movement disorders are very hard to quantify. If you have ways to quantify this more accurately than before, then that means your effect size measurement becomes a lot better. So if you are running a trial, if you want to discover a new drug or a treatment, potentially becomes a lot easier if your AI can measure a lot better, measure the differences better than a human can.
Yeah.
So, yeah, makes sense, right?
It makes perfect sense. Hello and welcome to another episode of the Dev and Dog podcast. Today we'll be talking about biomarkers. Josh, do you want to introduce us a bit?
Yes, so in this episode we're going to talk about biomarkers or biological markers. It's a really big topic, so I just want to talk a bit about how biomarkers have changed medical practice in the last 50 to 100 years. And then we talk about the more present bit, which is digital biomarkers. So how these biomarkers have changed in the last couple of decades to become digitalized, and how we can apply that and AI to change our practice. Okay.
Yeah.
So let's start from the top. Okay, so let's pretend I'm a doctor in the medieval period, right? And I'm going around, I'm examining patients, and this is the part of the medical practice that I view as core to the kind of physician, right? The doctor-patient relationship is always going to be there. The ritual of seeing the patient, taking a history, examining the patient. This more or less has not changed in the last several hundred years, and there's specific ways we can do that. There's a lot of structure to the history and the examination that we learn in medical school. Now, since the, let's say, mid-1900s, there have been more and more tests. So this can be, if you ever go to a doctor's, you might get a heart trace, an ECG, a chest x-ray. You can get scans of your head if you have a headache. There's a million things we can do now to look into your blood, your organs, non-invasively or invasively. And this has really changed practice. So I think I work as a neurologist, so we see a lot of brain conditions, right? And I would say, speaking to the consultants, it's changed massively the last 20, 30 years because of the availability of CT scans and MRI scans of the brain and spine. In the past, a patient would come, I would examine them, and then based on the examination findings alone, I would make the diagnosis. I'd probably start the treatments and then gauge how that treatment does. Now, with all these new imaging techniques, we can also get cerebrospinal fluid, so we can put a needle in your back and take the fluid out of your brain and spine to see if there are any bugs, any malignancies, any cancers. This has changed practice completely, because in the past we would clinch our diagnosis from the examination and we'd say, okay, I think it is this, let's go for this treatment. Now We're saying, I think it's this. But anyway, let's just get the MRI head. Let's get the cerebrospinal fluid from the back. Let's get an EEG recording of your brain. So this is now completely changed.
Okay, so am I correct to think that like when you are doing those examinations at tests, you are basically looking for biomarkers?
Yes.
Okay.
Yes. Yeah, so you can say these are different types of biomarkers, and broadly speaking, you can group them into imaging biomarkers, you can group them into pathological biomarkers, so taking things from biopsies or things from your skin to look under a slide. And then there's also, I guess, the kind of bodily fluids, so like blood, urine, anything like that, microscopy biomarkers. So this has changed completely.
Before we go any further into that, can you define a biomarker? Like, what is a biomarker? I think I have an idea, but I don't know the definition.
Okay, I'll give you the World Health Organization definition of a biomarker. So a biomarker is any substance, structure, or process that can be measured in the body or its products and influence or predicts the incidence of outcome or disease. I mean, in normal speak, that just means anything that we can measure from in the body or from the body, and it then becomes a good predictor or correlate to some kind of pathological or disease process going on in the human.
So like your body temperature, is that a biomarker?
That is a biomarker for infections. So one common thing we ask for infections, are you having fevers? Are you having sweats? Because that tells us that the pre-test probability of it becoming an infection becomes way higher, because we know that's a linked response to infections.
Mm-hmm.
However, there are good and bad biomarkers, right? Sometimes you can get temperatures for other reasons. You may just be hyperthermic from being in a hot sauna, or you could have autoimmune or inflammatory conditions that can drive your temperature. There are known brain conditions, autonomic dysfunction, that can cause your temperature to go up. And that doesn't always mean it's an infection. So each biomarker has its pros and cons. And this is very interesting. And we can talk about, how biomarkers are made in the past. But essentially, it comes from science. There's a big body of literature that people will examine one biomarker, or let's use a blood test, troponin. I don't know if you've ever been to the GP for chest pain. I hope you haven't.
I don't think so.
But one of the most common things that are done in the emergency department is people coming in for chest pain, and then there's a marker that everyone uses called troponin.
Mm-hmm.
Troponin is basically a marker of heart damage, and it's often released when the heart muscles are stretched from damage, and it releases.
Okay, but wait, just one thing there. So, is troponin always released, but in smaller doses, or like? I just want to understand, like, is there a certain level of troponin when it becomes a biomarker, or is it any level? Like, how? I'm just trying to understand how does that function. Like, does a biomarker require basically specific values? Like the same thing with fever, height, body temperature is a biomarker, but is it a biomarker only once it has a certain value?
Yes, just like any AI test or any technology or any drug, there is a kind of sensitivity and specificity to the test. So normally this is gauged from population studies or big studies. So they find what the normal limit is, and then anything outside of that normal limit, you can say is abnormal or associated with a certain disease or pathology.
Mm-hmm.
Yeah, so when you look at lab tests, there's always a range, and a big problem with these tests, which have been highlighted in recent decades, is that because the Western world drove a lot of these tests in the past, and the tests are normally done for, from an ethical perspective, they're normally done from people who are aged 18 and 65, and normally predominantly kind of white Caucasian. And more we're finding some of these biomarkers may not be as good on the extremes of age or for different races. One of the kidney tests, creatinine, we know is very different from an Afro-Caribbean compared to a Caucasian level. So the normal ranges can shift depending on those demographic factors as well.
Yeah, I think that's standard that medicine is made for white male guys. Lucky for me, unlucky for everyone else. But
yeah.
But I would be like really interested trying to understand like the percentage of tests that are really, or percentage of those biomarkers that are really made and measured on basically white Caucasian people. How many of those do take into account, like, would be very nice to understand in the modern medicine today, how many of those, like, what would be your guess? You would say how many of those have really had like diverse studies where different sex has been taken into account, where different ethnicity, where different even backgrounds have been taken into account, like.
Yeah, well, unfortunately, if you look at the literature, a lot of these tests and the values were derived, in the 1900s. And back then, even if they wanted to be, diverse and inclusive, and it's probably not very easy at that point, just because of the population here. So from studies I've seen, anywhere between 60 to like 90% white Caucasian. In these studies, so it's not super diverse.
Yeah.
Yeah, and you're right, more male than females.
So I'm still a bit like missing the connections here, like the connections between a test and the value, the outcome of the test, and when does something become a biomarker? Like, who is deciding when is it a biomarker? How is it decided? Like, I'm just missing a bit the connections. I can measure my body temperature and be like, okay, it's slightly higher than normal. Is that now a biomarker of something, or does it need to be a lot higher? Like, what? How is that done?
That's a great question, and it's a very complicated question. I'll attempt to answer it, but I don't think I'll be able to answer it fully. I suspect it's a very grey area, right? Like, tests are made and biomarkers are formed. So tests are made, and you have papers that measure the utility of that test. At some point, that utility becomes widely accepted and duplicated in different studies, maybe in different demographics and different conditions, and then and usually there is a very good pathophysiological process that underlies that marker as well. So if you have a disease that causes significant inflammation, and then you do a scan and you can see what looks like inflammation on the scan, that makes a lot of scientific sense. So I guess those biomarkers will be clearly accepted, whereas others may not be as easily appreciated and may need, you may not see it with the naked eye, but with studies and clinical validation, then maybe it's more widely accepted. There are currently still many of these tests being developed, especially, I know of many in the neurology field, and they have not been kind of fully validated clinically. So what we say is, when we see a patient and we think of this test and we have a discussion between the experts, we say, well, this test has not been clinically validated yet. So we know, we know that this kind of change in the cell can occur in this disease, but we haven't had the clinical studies to back it up, so we shouldn't use this in clinical practice. But, yeah.
Okay, so I think I get it. So like with tests, you just measure something, and then if you measured enough and see a correlation, you make a study, and then other people can also make a study, and then over time it becomes a biomarker.
Yeah. Well, some biomarkers are obvious. So, if you take a tissue biopsy and you see cancer there. I mean,
yeah, of course. I mean, I get it, yeah.
In the last 50 to 70 years, everything is being measured, everything is being digitalized, and this isn't just medicine, this is everything in life. There are metrics for everything, but because we're measuring everything, this has led us to quantify stuff. So I think using that fever, using that fever example, in the past, a patient may come to you and say, "Oh, I feel feverish. I feel like hot and cold." But as a physician, then you can't, if you don't have the instruments to measure it, you cannot quantify it. So now we even quantify it, right? Oh, there's a high fever, there's a low grade fever. High grade fevers we think are worse. So through that measurement, it becomes a more useful, quantifiable thing. It's taken away from the subjective to the objective, and then we start to gauge treatments, gauge response, gauge prognosis on these markers. We keep measuring these markers, and we treat it until the markers go up or down or whatever. So that is the really big change in practice. Going back to neurology, we think it's a disease, but now we don't treat it until we get confirmation from the tests. So we might get an MRI scan, and we can say, oh, there's inflammation in the brain, just as we had thought. Now let's treat it. And now most guidelines say, even after the treatment, repeat the scan in 6 months and see if the inflammation is gone. So there is now a strong reliance on these modalities, these biomarkers, in everything that we do, every way that we practice in medicine.
I just thought something interesting. This is like, what happens when we will go back to biomarkers, but this is just a bit of an escapade to AI side. Like, what happens when the AI can determine a disease or something based off of a measurement, but we cannot? Like, you measure, I don't know, EEG of a person, and then the AI looks at that and then tells you, oh, this is an indicator of a disease. And you're like, oh man, but I don't see it. Like, will there not be a bit of a conflict between the old definition and the old we measure, we understand, we see, to the new one where something just tells you with a 99% confidence this is a disease, but you have no idea?
Yeah, so it's like we measure, the AI sees, and we don't understand.
Yeah, exactly, yeah. The AI just looks at that and it's like, oh, this is cancer. Like, what? How? I have no idea. Like, we don't see the biomarkers, and we cannot get we don't understand. Like the same thing that happened with the retina scans, where AI is able to determine sex based off a scan, but no human can. And the same can be, I don't know, for many other conditions.
I think, like your example, it's already been happening. Yeah. It's already happening. There is a really nice paper that we can link where someone. So in the past, when you have heart failure, you have to diagnose that either through a blood test or through an echocardiogram, so a jelly scan of the heart. Now they found that basically with a stethoscope, you can a digital stethoscope. So when you listen to the chest, you can record those waveforms, and you can apply it to an AI, and that can diagnose with pretty reasonable metrics whether the patient is in heart failure or not. So this is completely new, right? So you're using essentially sound waves to diagnose heart failure. And in the past, it's always been blood test or imaging technique.
But do you think it is necessary that the doctor understands? Like, the doctor can look at an EEG, ECG, understand that and understand why is there heart failure. But with listening to a digital stethoscope and the AI just tells you, like, I think the changes the AI is listening for are so small that a human can, like, is there a need for a human to understand them? Or do you think it will more be, oh yeah, the AI said it's that, so what can I do? It's that.
Yeah, I mean, this is a topic we've spoken about quite a lot in our previous episodes as well, like with LLMs, like, do we need to understand the tool to be able to use it? And this opens all the talk about interpretability of the model. Maybe they should highlight things or tell us how they came to these conclusions. So if they can do that, then we can know when it's wrong, or we can interpret for ourselves. I don't know, maybe one day AI will get so good where we just blindly believe in it, but I don't think we're at that stage, and I don't think that's the path we should start on. We still need, it still needs to be interpretable to an extent.
Yeah, I agree.
So, what we've just talked about, using AI on top of our measurements to then develop biomarkers. These are digital biomarkers by definition. This is towards the new way of diagnosis and using biomarkers.
So, like, what's the difference between digital and, like, non-digital analog biomarkers? Like, do you have an example of one digital and one analog? Is that even the name? Like, how do you call the non-digital biomarker?
I've never heard analog biomarker, but it makes sense. You're really pinning me down here, because I don't think... The problem is, even biomarkers is a fuzzy definition, as we alluded to. And then our digital biomarkers, actually, I can actually link you to a resource that I read recently. So I read a Nature paper. This was published 2022 that tried to define digital biomarkers.
Okay, interesting that it's only defined in 2022. I mean, we've been talking about biomarkers for whatever decades, and only now it's like, oh, but biomarkers are these. We don't exactly know what they are.
Well,
not biomarkers, sorry, digital biomarkers.
Yeah, no, we are. That's what I mean. This is nascent. This is a very new field, and so look, this Nature paper 2022. We'll link it. It says, it gives some examples. Okay. A diagnostic biomarker an example is a biomarker, used to detect or confirm the presence of a disease or condition. And in this case, we use the example of an ECG. So to diagnose an irregular heart rhythm, let's say atrial fibrillation. Now, the digital biomarker example would be an algorithmic classification of those features extracted from either the ECG trace, or better yet, optical sensors from a wearable device.
Okay. So then it basically means, like, digital is when you applied some AI to it, or some
yes.
Maybe not just like pure AI, but statistics, modeling, something in that area.
Yes, and the FDA has also attempted to define a digital biomarker. So the FDA defines a digital biomarker to be characteristic or a set of characteristics collected from digital health technologies that are measured as
that makes those digital health technology. What is that? That has no meaning. What are digital health technologies? Let's keep going down the
definitions. Okay, let me define digital health technologies. I feel like we're just going crazy. Look, I feel like our listeners are probably leaving by now, because just grab a dictionary, go on Google, look it up. But basically, it's anything that's you know, a system that uses computing platforms, connectivity, software, or sensors for healthcare or related uses. So let's just say smartwatches, I don't know, like your...
Okay, but basically, like, what you were just saying is like none of that is really defined. It is all like some very, very fuzzy definitions of what does it mean. Like even that one is if it's using sensors. What is that?
Yeah.
That's everything. Okay.
Well, it's everything now, right? We're measuring everything. You know, I'm wearing my smartwatch now, and you know, it's measuring my heart rate. So, I look. The reason they published this paper in 2022 was clear, because no one really knows where you draw the line between the biomarker and the digital biomarker. They've tried to say it's the way you measure it that makes it become digital. But I think, like you said, there's a middle ground where you apply an AI algorithm on top of existing analog, let's say, measurements. To me, that is also a digital biomarker, because that's not something, you know, right? So maybe we should write to the editors here and tell them they kind of missed out like a middle ground here, right?
Yeah, I think that makes sense. But yeah, I think, like you said, I think it is very early days, and really, like, whatever, even if you're saying this field is there for like 20-30 years, that's a very, very short period of time. So I think, and especially with respect to AI, you maybe have only the last decade where we properly have started something. So I think there is a lot of time is needed.
Okay, let me try and summarize all of that in as best as I can.
Okay.
So in the last, let's say, 100 years, the way we practice medicine has changed. Because everything is being measured in a quantifiable manner, there is more digitalization, and everything has been centered around this concept of biomarkers. And that's changed the way we interact with patients and the way we practice medicine. And then now we are going into the age of digital biomarkers, where we're either putting an AI on top, and we're also measuring things in all kinds of ways, from our smartwatches, from our sensors, from cameras, everything. And that, I feel, is the way we're headed, and will change the course of how we practice medicine in the future.
Okay, very nice. I think that's very good. A lot more things make sense to me now. Did you also want to address, like, where do biomarkers fail? Or where are they not the best?
Yeah, so this came into my head when I was reading around the literature. And all of these gains, all of this momentum and progress in medicine, we attribute it to evidence-based medicine. I don't know if you've heard this term, but basically for our listeners is this change in our thinking. So applying the scientific method to medicine. So that's via clinical trials, that's via taking large proportions of the population and big data to understand whether an intervention is working or not. And this ties in very closely with biomarkers, because how do we know if something is working or not? We rely on objective measures, because it's not enough to go around and ask people, oh, we've given you some antibiotics for this infection. Are you feeling better yet? You know, this is not a scientific way. So instead, we're measuring blood tests, the white blood cell counts, the inflammatory markers, the temperature. And in my head, I'm like, this is all well and good. And for sure, this has changed practice completely. But there are many diseases that are not easily quantifiable. And I feel like these are the diseases that we are now seeing are more neglected in research and more neglected in funding and understanding in the general public. I'm of course referring to things, I guess, you can think, what is hard to measure? Well, often things that are neurological or psychiatric or subjective becomes very difficult to measure.
Okay, sure. I think that makes sense. Like, what would be some examples of the diseases?
So things that are hard to quantify, for example, Alzheimer's can affect many domains of your function, memory being the most known. It's very hard to know, how can you measure memory effectively? And also, how do you quantify how much that memory has an impact on their life? It depends on the case, right?
Yeah.
Like if you're living with your family, it's probably fine that your memory is not so good if they're happy to keep an eye out and help you with things and remind you. If you're living alone, that's a different story.
I mean, it's not fine in either case. I would not like to lose my memory. But no. Yeah, I agree that, with respect to what's more dangerous or not, then it makes sense.
Other examples are, of course, things like mental health, depression, bipolar, schizophrenia. All of these things there have been attempts to quantify, but it's very difficult to quantify in an objective way. And there's other things like movement disorders. So things like Parkinson's or Huntington's, these are all conditions that affect the way you walk, affects the way you move. So let's say you're designing something to treat that. It's very hard to say, like what's your objective measure? It's very hard. Or seizures, like how many seizures you can quantify, but the nature of the seizures, how disabling seizures are, that's also not easy to quantify.
So what I feel like you're saying is just that determining the biomarkers is very hard in these cases, or we don't even maybe have proper biomarkers.
Yes, I'm saying there are certain diseases that are much harder to quantify and therefore receive possibly less attention and funding, because it's harder to know what's right and what's wrong to do in some of these cases.
And what would be an example of a test that that you are currently using in your daily work life?
Thanks for asking. Let me put this up on my screen. Okay, this is something we've been using a lot and still use. I've never read this paper and I never thought I would, but here I am. So the hospital anxiety and depression scale, this is used across the United Kingdom and in the US and God knows where else. I had no idea it was published in 1983 and we're still using this bloody thing now.
Man, I cannot believe that.
Well, I guess there's nothing wrong with when it was published, but I think there's certain things in this that are quite interesting. So this was derived from some researchers in Leeds University in 1982. And like we said, here, I told you. So they chose adults from 16 to 65. So that is always kind of the routine thing to collect. The interesting thing is they only asked 100 patients to validate this questionnaire. So what they did was patients would come in, some depressed, some were not. They were given this questionnaire to fill out, and then they would see a professional after, and then the professional would decide whether they did in fact or did not have depression and anxiety. I'm just going to scroll to some of the tables here. Can you see this table?
Yeah, of course.
So there are these 100 cases seen by the professionals. So I think it's like you said, essentially they've tried to curate a normal range of what is depression and what isn't depression. Okay. And you can see from scores of 0 to 7 is considered a low or normal score. And in this case, you can see there's 69 patients that took this and received a low score. 57.
Wait, can we just have a look at the questionnaire so that we know based on what is the score determined?
Oh, yes. This is the questionnaire. So these are the questions that you ask, you will be asked if you were a patient there. So I feel tense or wound up, and then from it, you get a score of 0 to 3. Most of the time, a lot of the time, from time to time, or not at all. What do you think of that?
This makes no sense. The more I understand about it, it's like, what?
How about this one? I get a sort of frightened feeling, as if something awful is about to happen. Definitely, a little. Yes, it's very definitely and quite badly. Yes, but not too badly. A little, but it doesn't worry me. Not at all.
You know what? This is very... it is fun, interesting how this was developed in the UK, and how the second option you have here is yes, but not too badly. Basically, whichever UK person you ask, how are you? It's not too bad. And not too bad is basically like means everything is fine. So you are so you are telling me that like there is a difference is very definitely and quite badly. You get 3 points for that, and yes, but not too badly, you get 2 points, which basically means like it is almost the same thing. But if you would ask me, I would use those two answers for very different things. Like if someone asks, yeah, it's not too bad, that for me means like, oh, whatever, it's fine, I can survive that easily. Yeah. But the first answer is like, oh, this is a disaster, no one can live with this.
And this is question design 101 as well, because they're asking two questions in one, right? They're asking, are you afraid? And do you feel like something awful is happening? You shouldn't do that. So the answer is very definitely and quite badly. That's how can that be an answer?
Oh, true, exactly. That is, oh my god, that's a disaster. You don't even have all the options there. Maybe I am frightened, but don't feel bad or whatever.
How about this one? I get a sort of frightened feeling, like butterflies in my stomach.
Aren't butterflies like the awesome stuff? Is that not like you are in love and you feel butterflies? What happened?
No, these are bad butterflies that exist in the UK. How about this one? I can enjoy a good book or radio or TV program. I haven't listened to the radio in decades.
No one even knows what's radio anymore. What?
Wait, be careful. Like half our demographic for this podcast is 40 plus, apparently. So, nice.
I mean, but it makes. Can you believe that the phone is not mentioned? Like, what?
What's a mobile phone, man?
Yeah, there is no phone. There is no I am on my PC or something. There is no I'm on TikTok 7 hours a day. And there is a radio and TV program. I haven't watched TV in at least 5 years.
Yeah.
Okay, but do they say anything about the demographics of the population, of the people in the study? Like what's the sex, ethnicity or anything?
That's a very good question. I can't see anything on this. And I did read around. No, there's nothing about... they were requested to complete it anonymously, giving only their age and sex.
Okay, so maybe there is somewhere an info about...
But no, nothing about race or demographic. And I can't even see how many were men, how many were women. Clearly that was not the priority back in the day.
Sorry, can you just type sex and scroll through the findings?
They didn't report it, which is also
okay, so they...
bit of a no-no.
They had info about sex, but they didn't report it. Okay, fun.
But yeah, nothing about age, nothing about race. Or
yeah.
But look, we've gone through some of the interesting questions that they asked, and now should we just break down one of the results table, just to bring it back to this interesting topic of biomarkers. So maybe let's focus on the depression bit. So 100 cases, took the questionnaire, and then was reviewed by a professional, and then determined whether they were depressed or not. So based on the scores, they've then retrospectively, I guess, well, they've decided what scores had the best sensitivity and specificity to kind of indicate that they were depressed or not. So 0 to 7 would be a normal score, because 57 of the 69 patients that were interviewed with score 0 to 7 were not depressed. One case was definitely depressed, and 11 were doubtful, so not too sure. So this, to me, this is not a great scale, to be honest, given that you have 11 doubtful.
Exactly, that's like 20%. That doesn't make too much sense. Like 20% of the patients in your group there are possibly depressed or possibly on the border.
Yes. And so 8 to 10 they thought were borderline cases, where 8 were not depressed, 7 were doubtful, and 3 were definitely depressed according to the professional review. So this is, I guess 8 to 10 is when you should be cautious in that. I guess that's so you have kind of like a 50-50 chance there of being depressed or not if you score between 8 to 10. Depending on how you answered the questions, depending on what you interpret the butterflies were. Because that was 4 points, potentially.
Yeah. And the last one is...
so if you score 11 to 21, you're likely to be depressed, because one patient that scored that was not depressed, 4 were borderline, and 8 were definitely depressed. So 8 out of 13 were depressed.
I mean, it's fine, but it's... To be honest, this to me seems like a study a master students would perform, and they'd be like, okay, it seems okay. We probably need a study on whatever 10,000 patients or more or something, so that we can be sure that these questions make sense. We need to refine them at least 10 more times. We need to go through everything a million more times and just be sure and validate in different hospitals, in different areas. And it feels like this is the beginnings of the beginnings, the first study ever that was done really by like one researcher, on top of which you build and go higher and all of that. It doesn't seem like a study that's that should be used in practice.
Well, yeah. I mean, look, they did apply this, the statistical correlation test to it and stuff. But yeah, it's a very small
I don't buy that. There is no way. Like, you applied a couple of tests, and it is obvious just by looking at it that 100 people are not enough, especially when out of those 100, 60 are not depressed. So you basically made your whole study on 40 people in total, where diversity was 0, wherever, like, and that was based on a couple of questions you have, which were designed, whatever,
questionable at best.
Yeah.
But yeah, this is used to this day. 30,000 citations in the research world. Big.
But wait, how does this relate to biomarkers? Because to me, if I'm looking at this, I would say this is not a biomarker. This is not even measurable. Like, it is extremely subjective. There is no objectiveness here.
This is a biomarker, although not perfect, this is a biomarker for depression and anxiety, and subsequent clinical trials and tests for, CBT, for, for drugs, for antidepressants. All of this, that was used as the marker, one of the metrics to say that the treatment worked or didn't work.
But...
So you can say, I give the antidepressants and your hospital anxiety disorder score went down by 5 points.
Yeah, your biomarker. But to me, my initial thought was biomarkers are objective, measurable things. This is obviously based on something subjective because you are asking people to answer a couple of questions.
Yes, in some ways, but also, I think this point was just to illustrate that certain disease processes, even though we try and be objective, because you can argue these are semi-objective markers, or I'm sure the researchers will argue this is a bit objective and a bit subjective, but the point is that this has then become a metric in which subsequent treatments, research, tests have been using to then quantify the potency or efficacy of an intervention.
Man, I saw recently a study where they measure the way you type on your keyboard, or I'll link it if I find it, or was it on your smartphone? And based on that, they predict are you depressed or not, or how depressed you are or not. I'm 100% sure that's a better measurement than what this paper is. I'm 100% sure just the way I type on my keyboard is a better measurement and more quantifiable than me answering 10 questions.
Wait, how you type or what you type?
No, how you type. Not even what you type, just how you type, how you press
How
the
do you
keys.
type when you're depressed?
Yeah.
Slower.
Yeah, I don't know. I didn't read everything in detail. It's
No,
just
but
like there were some movements or something that you have done differently that I was able to notice. This was like, and this again, I feel like this is really the initial study on which you build everything, or on which you can then further expand your group and everything. But it just feels like there is so many better markers for depression or for anxiety than answering 10 questions. And even if you would do a questionnaire, like, you can really make it much more conversational. You can use today's AI models that can chat with you and have a half an hour conversation and be like, oh, okay, come back with a much more quantifiable, objective answer. Because I do think that the AI models can be a bit more objective.
Yeah, for sure. I have no doubts if you spoke to an AI model at length, especially, over time, they can definitely detect if you're more depressed on that day. Or
and like looking at your tone of your voice or the words you use. I'm sure it is very hard for even a psychiatrist that is talking to you understand that, oh, at this point you now used a different word than you have used 3 months ago. There is no way for a psychiatrist to do that because, 3 months ago, they saw 1 million patients in between. They have no idea what happened. But for an AI that has perfect memory, that can look at every single of my previous encounters and be like, oh, based on the tone, based on the words you use, based on the movements you're making, based on the way you're walking, typing, everything all combined, I'm sure it can be 1 million times better than 10 questions.
Yeah, and there are studies showing that measuring the way you talk, they can have a good degree of certainty that you then go on to develop diseases like Parkinson's or Alzheimer's based on your speech. This is published, and we can also link the paper. And this leads us on to the strength of digital biomarkers, of which there are many. So it's definitely conceivable that machines can quantify, especially more of these subjective disease processes. So let's dive into a paper that I read recently as well. We'll put it on the link, but it's from a group from Imperial, and they basically, do you know those funny suits you wear for like CGI films, like have you watched Avatar and stuff?
Gollum, when it's all like balls or something on them with markers and something, and then they can track movements.
Yes. So what they did was put these suits on people with neurodegenerative movement disorders. So in this case, there's two papers. One is they put it on people with Duchenne's muscular dystrophy. It's a common type of kind of to keep it simple, It's a muscle disorder that is often inherited and presents itself early in life. And there's a similar one called Friedreich's ataxia. So they put this suit on these patients and got them to do the usual tests, like walking around, checking their coordination, but also letting them just do things normally. But because how we would measure it as neurologists before all of this would be to do quote unquote objective tests. So it would be things like, walk 10 meters and we'll time you, or like touch my finger. So this is how we test for coordination. Touch my finger, you touch your nose, touch my finger again, back and forth as best as you can. And we subjectively gauge, how good they are at localizing to the finger.
What? How is that possible? I don't get this. I feel like we are doing like kindergarten science or something. What? How can it be like you are testing? Is that test like for coordination or?
Mm-hmm. It's hard though. How do you quantify coordination, right?
I don't know, but tricky. I would try a bit more than that. I don't know. I would try to measure you performing 100 tasks and time them. And I agree that it takes a lot of time, but I don't know. It feels like I do this for 10 times and you're like, okay, that seems fine.
Yeah.
What?
Yeah. And you know how we test for strength? We will get you to isolate certain muscles and then push against me, and then I feel how strong you're pushing, and then I can say, yeah, that I can grade it. I'll give it some numbers, but in reality, it's highly subjective as well.
Oh man, I've done that test. I've done the test of, I don't know why. I cannot remember now. I've done the test. I was thinking, what are they doing? I think the first time I came to London when I was doing the full physical or something. And I know it was the test of like push down, or I should like squeeze their hands.
Yes.
And then it was like, squeeze a little bit, and then I squeeze a little bit, and squeeze as hard as you can, and then you squeeze as hard as you can. Like, what are you measuring with that? It doesn't make sense.
How strong your fingers are, your grip strength.
But it doesn't make sense that you're comparing that, because if I have done a ton of exercises and rock climbing, my grip strength should be 100 times stronger than me not doing it. Like it is all really relative to myself, myself, and basically what am I doing? How am I working out in that area or not?
But that's where a good doctor will that's why it is an art and a science, because they'll gauge whether you are that kind of person, ask you what you do. Like, yeah, if you're a manual worker and you've been working your whole life, obviously your grip is a lot stronger than someone who's, doesn't use their hands as much for their job.
Okay, I don't know. I'm just feeling like today a lot of those tests can really be digitized. Instead of me squeezing that, why not squeeze something that measures the pressure I can exhibit, and then based on that, okay.
You have grip strength devices, actually.
Yeah.
You can squeeze to give you a number, how many pressure you're exerting.
Exactly, and do that like every month or something, so that you can notice a degradation, and not once between 5 years. I mean, God knows what happened.
Yeah. So there are ways to improve it. But what this team did was they wore this computer suits and basically found potential digital fingerprints, which then correlate very well with the kind of disease severity.
Wait, just to clarify. So they basically had them perform tasks that you would have them normally do, like the walking and all of that.
Yes.
But they measured every single movement with this full body suit that is measuring basically how you're moving your legs, your joints, everything that is happening with your body in like as much detail as possible.
Exactly.
Okay.
Exactly that. And they found some potential, some useful digital fingerprints, they call it. I'm not going to go through all of them. You can read the paper, but there are things like hip orbit area, so the kind of area generated by hip movements in the 3D plane. There's like, and they can also work out kind of average joint velocities, so the angular velocities as they move, or and you know, like Tmax, the extreme velocities, the variabilities. So this is really interesting because it's quantifying things which we probably do in some subjective, subconscious way. But now you can put it to digital measurements and actually correlate that with their function and their disease. So it correlates very well. Yeah. And interestingly, these fingerprints. So for the patients with Friedreich's ataxia, they have the genetic, because it's a genetic condition. They have the genetic burden of that disease as well. So they've got that test. They know how the kind of FXN kind of gene expression, so how strongly these genes are expressed. And they found that from these fingerprints from the suits, it correlates very well with the genetic expression of this defective gene. So that's very cool.
But this is basically what we were just saying. It is like, take AI and measure things, not take AI, take digital measurements and plug it into an AI model, and you can measure things in significantly more detail. Like for an AI, it's easy to determine that the velocity of whatever, the way you are moving your hand changed by 1%, but for me, a human looking at someone, it's completely impossible that I know, like, oh, they are now 0.1% slower than they were a month ago.
Exactly. Because it allows quantification and therefore monitoring of the disease. But yeah, look, you know, one question I had in my head and that has transpired is also, why do they need to wear a suit, right? We're probably getting to the point where with a couple of cameras you can generate a pretty high-res 3D image and you know, measure the joint velocities that way.
Yeah, I mean, you can do that with basically one camera today, and you have the pose estimation, which is probably perfect for these. Which basically, you know, when it's like given a body, it draws the wireframe of the body, and then it's basically estimating movement of your limbs and basically movement of your whole body in detail. And you even now have the 3D reconstruction just based off of one video feed, so you don't need 5 cameras or something. I mean, all of this is AI based and not 100% accurate, but it would be very interesting to understand, can these be used and how much better or worse? I don't think it will be better, but how much worse is it compared to wearing a full body suit? Because if it's 1% worse or 5% worse, that doesn't matter too much, given that it is a million times easier to record a video versus wear a full body suit and everything else.
Yeah, because then you can record it from home. Patients can self-monitor.
Yeah.
But you know, just to wrap it all up, I think where all of this is going is, if you have better biomarkers, especially for these diseases which are hard to quantify, and you know, movement disorders are very hard to quantify. If you have ways to quantify this more accurately than before, then that means your effect size measurement becomes a lot better. So if you are running a trial, if you want to discover a new drug or a treatment, potentially becomes a lot easier if your AI can measure a lot better and measure the differences better than a human can.
Yeah.
So, yeah, makes sense, right?
It makes perfect sense. I mean, especially measuring that over time and measuring it more frequently. If you could make that bodysuit, if you could basically just record a video, you can record yourself at home once a month, and then basically track over whatever 12 months, 24 months, whatever amount of time, you can track the smallest progress ever. Or if you need more detailed measurements, you can do that every day. It is like so much more it is just much easier, and it doesn't put a burden on the healthcare system, because you just record yourself at home, send it to the hospital, it is digitized, processed by an AI model. Doctor can just look at it and be like, okay, everything is fine, go ahead. So
yeah. And it's also personalized, and it becomes, then what the baseline is. And you can have this with smartwatch. I question how accurate my smartwatch is on measuring things like my heart rhythm and my heart rate, but at least it knows what's normal from day to day. And when I depart from that normal, it can flag it up.
If something changed majorly, you can be okay, something's not right. It doesn't have to be majorly, it's just if there is a gradual change over time. Like a sudden change, okay, whatever, but a gradual change over time, over months, means okay, something's not the best.
Okay, well, I hope I've given a good taste to the complex topic of biomarkers and digital biomarkers, and I'd be interested to see where this will head in the next decade. It's a really exciting field, in my opinion.
Yeah, I think this is awesome. I love this episode. I think I learned a lot. I would prefer to do more of the medical side so that I can ask a million random stupid questions. So I think this is great. I hope the audience will also love it the same way I did.
Yes. Okay, well, I'll see you on the next one.
Thank you very much for listening, and we'll see you next time. Bye-bye.
Bye. Bye.